So this is the third lecture, or the third video in the series of critical appraisal, and in this video we're going to be taking a look at RCTs, randomized control trials. Before jumping into the actual critical appraisal, let's just quickly talk about what is the most important consideration that we want to make before actually designing any sort of experiment. And that is that taking into consideration that we want to know that the intervention was actually the thing that caused the difference in effects that we saw between the two groups. So the thing that we want to know most about our study is that it has good internal validity. And the way that we do this is by minimizing error. Okay? Minimizing error. And really, we have to focus on two different types of errors. So in minimizing error, we have systematic error, and we have random error. And the difference between systematic and random error is that systematic error is the variability, the differences in the outcome that we can see that are basically preventable and that we can explain. Random error, on the other hand, is the variability in the outcome that you can't explain because it occurs purely by chance, right? So now knowing this, that in any sort of study design, we want to obviously minimize error to improve our internal validity, we can go into talking about RCTs. Because when we talk about RCTs, really we're going to talk mostly about internal validity and what we can do to minimize any sort of biases that will occur that might influence error. Excuse me. Okay, so the general design of an RCT is that you take a sample of people and you essentially just randomize them. So you're going to randomize them into a treatment group, and you randomize the other side of them into a control group. And then what you do is you follow them for a specific outcome, and you'd hope that the outcome in your control group or your treatment group is different than the outcome in your control group. And R for randomization, right? And before we can talk about how we minimize bias, let's talk about first why we'd like to, or why we want a control group, right? So we're going to talk about first why we want a control group, then we'll talk about randomization. And the reason why we want a control group is because it's going to help us compare the effects to a treatment group. If we only had just this arm of the study and in our design, then we really wouldn't be able to discern any cause and effect relationship. It could just, we wouldn't be able to discern anything. But considering that we have a control group that doesn't get the treatment, now we'll be able to tell, now we'll be able to compare the two groups and tell whether the outcome, or whether or not the outcome was actually a result of the treatment. So the control group is there to help us compare the health outcomes between the treatment and the control group. So there are a couple of different controls that we can have. Obviously, the one that's most well known is the placebo, right? And a placebo is essentially something that's biologically inert, but it looks as similar as possible to the active intervention. So if it's some sort of drug, then our placebo is going to look almost very, very similar to the treatment, to the drug. We could then also have a sham as a control. And a sham is, for example, a faked intervention. And let's say we're doing some sort of surgery, right? And one part of the surgery is absolutely necessary for some sort of therapeutic effect to occur. Well, a sham will take that entire intervention, that entire surgery, but it will omit that step, that therapeutically necessary step. We could also have no treatment, which I'll call NT, or delayed treatment, which I'll call DT. And essentially, no treatment is basically the person will get the treatment after the study period. Delayed treatment is that they will get the treatment later in the study period. But this is one of our control groups. And finally, we have active treatment as a control. So this is something that already exists. It's an existing treatment. And obviously, if an active treatment is already present, it's not ethical to give a patient a placebo or a sham, right? You want to make sure that you have ethical standards when you're performing your design. So if an active treatment already exists, you want to make sure that you're not doing anything to the control group to harm them. So maybe you would want to give them the active treatment. So those are the different types of controls that you can have. Right? And that's the general study design of an RCT. Okay. So how do we limit bias in RCTs? In other words, all that stuff that contributes to our systematic error, how do we go about minimizing it? Okay. So the first thing you want to do when you start anything, when you start an RCT, is you want to make sure that you balance your prognostic factors. Okay? So you want to balance prognostic factors. And prognostic factors are essentially things that could explain the health outcomes that happen at the end, but have absolutely nothing to do with the intervention being tested. Okay? And you want to make sure that these prognostic factors are balanced between the intervention and control group, so that if a prognostic factor could have explained the outcome, then it's equal both in the intervention and control group. Let's say, for example, the prognostic factors weren't balanced and the treatment group had more of these prognostic factors. Then we could just say that the outcome that we saw in the treatment group was because of these prognostic factors. So that's why it's very important that we balance these prognostic factors. And one of the strategies that we can do to balance these prognostic factors is randomization, is a sort of randomization. So we do, it's called stratified random sampling, or stratification, essentially. Stratification. And the way that stratification works, essentially the definition, first of all, is it's the process of separating the sample into several subsamples that allow us to balance these prognostic factors. So the way stratification works is that, let's say we have our population right over here. So there's a whole bunch of people in our population. And let's say we had a couple of different prognostic factors. So let's say we had male, female, and just people who identified as other. Right? Well, in order for us to stratify, what we do is we sample the population and we essentially find people into these groups. We put people into these groups. So after stratification, now that we've put people into groups based on the prognostic factors, right? And there might not be an equal number of people in each of these groups, but there will be an equal number of people in each of these groups receiving an intervention and control. And we'll see that all work out at the end. But just keep in mind that when we've done stratification, right, we've stratified our population based on certain prognostic factors that we've identified as being important, these groups might not have an equal number of people. But that's okay. Because the second technique for an RCT, after we balance our prognostic factors, is called randomization, right? So randomization now is the process by which we're going to leave it up to chance, right? We're going to make sure that the people who get the treatment and the control are getting the treatment and control, not because of what we decided, but because there was some sort of element of randomness in the decision. Okay? And one of my favorite ways to perform randomization, and one of the ways that a lot of people actually do perform randomization in RCTs after doing stratification, is called blocked randomization. But there are also other forms of randomization, like simple randomization. And simple randomization might be, for example, like flipping a coin. But what that does is it leaves things completely up to chance. And so what might happen at the end is that you might not have a perfect prognostic balance in treatment and control groups. right? And really, the only time we can get perfect prognostic balance by flipping a coin or using some sort of simple randomization technique is if we have a very large sample size, right? So randomization, we've talked about simple randomization. One of the ways that one of the methods that are used most often is blocked randomization. Okay, so before we actually talk about block randomization, I just recalled something that we might want to talk about for stratification. It's also important to know that we also don't want to have many strata, right? Too many categories that we divide our population up into will eventually lead to cells that might not get filled, right? And cells with no data, because no participant fits in this category, for example, are what we call an observed zero, right? And we usually don't want an observed zero, so we keep the stratification down to a minimum. Now, on the other hand, aside from an observed zero, we can also have a structured zero. And a structured zero is just a cell that's impossible to fill. Like, for example, a pregnant male, right? And you can't really assign it a zero value because that incorrectly interprets the zero as if that structured zero was a reasonable possibility. So we can exclude that structured zero from the data. But the point is, we don't want to have too many strata. So we just noted that maybe doing simple randomization is not the best technique. Well, blocked randomization is a technique that we can use. And what blocked randomization does is it puts people into, essentially what it is it puts people into blocks, right? So let's define, let me just draw a diagram out to explain this better. Just erase this. Okay, so you'll have a computer algorithm, and your computer algorithm is going to compute a block size. So a block size is essentially, let's say, a block size of 4 will basically have 4 blocks in it. And what this block represents is people who get the treatment and people who don't get the treatment, right? And for a block size of 4, there are many different ways that we can actually put this, arrange this order in. So there are 6 actually different combinations that we can arrange this in. I'm not going to draw them all out, but there are 6 different ways that we can arrange them in. Okay? And the idea for block randomization is that the computer algorithm picks a block. Okay? And let's just put our strata back here. So we had male, female, and then we had identified as other. Okay? So what happens is that our treatment and then control are balanced in the blocks, right? And you have to understand that the block size must be divisible by the number of interventions that you're studying. So we're studying treatment and a control here. So the block size, which for us is 4 here, has to be divisible by 2 because we have a treatment and a control. We could have also done a block size of 6. We could have also done a block size of 10, right? They're all divisible by 2. Now, what happens here is, let's say let's start with identified as other. We have an uneven number of people in this, we have an uneven number of people in this, and an uneven number of people in this. And by that I mean that the number of people in here don't equal the number of people in here, and that doesn't equal the number of people in here. But let's say the computer chose block size of 4, and it chose one of the possible combinations. So for this, it chose no treatment, no treatment, 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 right? And it'll continue to do that for this. But considering that it's a block size of 4 and we only have 2 interventions, eventually all the people in this group will have, or half of the people in this group will have the treatment and half the people in this group will have the control. So we've balanced this group out between treatment and control groups. Now the block randomization sequence, the computer algorithm, might pick another sequence for this block. So for this one we might have no treatment, treatment, no treatment, treatment, right? And eventually we'll continue to do this, right? And all the people in the male group will have balance. So half the people in the male group will have treatment, no treatment, and half the people in the male group will have treatment. And the same thing will happen in the female group. We'll choose maybe another combination. So we'll go treatment, treatment, no treatment, no treatment. And again, half the females will have treatment and half the females will not have treatment. So that's what I mean by it doesn't really matter that we don't have an equal number of people in each of these groups, because at the end we'll have an equal number, we'll have half the population having a treatment and half the population not having the treatment, having the control, that is to say. And that's the whole idea of blocking, right? And blocking basically insists that there's an equal distribution of participants in each strata between the intervention and the control group. And blocking is a very useful technique, but a bias could be introduced in this, right? For example, if for example, a study investigator was able to figure out that the first two did not have the treatment, and they knew the block size was block size of 4, then obviously they'd be able to figure out the next two people are going to have the treatment, right? So that might introduce some sort of bias. So what we can do is actually have a mixture of block sizes to prevent the investigators from knowing what comes next. So we might have had a block size of 4 here, but we could have also had a block size of 6 next, and then a block size of perhaps 4 again, and going on and on and on. And the purpose of having a mixture of block sizes is to ensure that the person who's investigating this doesn't actually know what's going to come next. So that's the whole idea of block randomization, and we could actually have one more form of randomization, and that form of randomization is known as minimization. Minimization. And minimization is essentially done by a computer. And it can be done by, usually is done by a computer algorithm. And what happens is that it calculates the imbalance within each prognostic factor and essentially adds all that imbalances together to give you an overall imbalance. And then the next person is put into one of the groups, one of the prognostic groups, either a patient or a control group based on the prognostic imbalance that would minimize that prognostic imbalance. But you might then say, well, is this really a true form of randomization, considering that this is all now done by a computer and we're really doing this to minimize prognostic imbalance? And that's a valid question, and in minimization, really only the first participant is randomized. And after this, it's what the computer algorithm decides. We say that the computer algorithm, after the first participant is randomized, minimizes the people into groups. So that's the whole idea of randomization. Alrighty. So those are the first two things of RCT study designs that we want to take into account. We want to make sure that we stratified. We also want to make by important prognostic factors, and we also want to make sure that we've randomized appropriately. Now, there are a couple of different biases that we might want to take a look at. Okay, and this is all going to pertain to internal validity. So we have selection bias. We'll take a look at detection bias, and we'll also put in performance bias. And then we can take a look at attrition bias. And finally, we'll take a look at reporting bias. So these are the 4 different types of biases that we want to take a look at. They're also identified in the Cochrane Risk of Bias tool for randomized controlled trials. So we'll take a look at these 4 biases and what we can do to minimize these 4 biases. So we'll take a look at the selection bias first. And there are, there are 2 different ways that we can minimize selection bias. Or actually, right now there's really only one way that we're going to minimize selection bias, and in order to do that, we're going to perform something called allocation concealment. Okay, and allocation concealment is essentially hiding the or the person who is making the decision about whether or not a person is eligible to take part in the study or not, is unaware of whether that person who is coming will be put into the treatment group or whether they're going to be put into the control group. So this is directly tied into, for example, block randomization. The person who's making that determination about eligibility is unaware of where we're going to put the person, whether they're going to be assigned to the treatment or control group. This person who's deciding the eligibility doesn't know. So this is a way to essentially reduce selection bias. Now, this actually is not a form of blinding, right? Blinding usually happens after allocation. This, if you insist to call it blinding, we can call this blinding before the actual randomization. And this is done to ensure that the allocation sequence is safeguarded before the allocation actually happens, before people are actually randomized into the treatment and the control group. Okay, so that's the whole idea of allocation concealment, and you always want to have it. And the second way that I said that we want to have to reduce selection bias is to make sure that we've had random sequence generation. Random sequence generation. Okay, and random sequence generation is essentially like block randomization, right? Whatever method we use to perform the random sequence generation, we want to ensure that it was adequate, that it was valid, and that the person then doesn't know. The person who's deciding the eligibility of the person doesn't know where the person, if the person is eligible, where they would go. And these two things are done in order to reduce our selection bias. Okay. Detection and performance bias, on the other hand, is reduced by blinding. And we can blind a whole spectrum of people. So, now this is going to refer to detection and performance bias. So blinding is done in order to ensure that the randomization sequence is protected after the allocation has happened, right? And what blinding does is it reduces the likelihood of detection bias and performance bias, right? And we want to make sure that we blind a couple of different people. So we want to make sure that we blinded the clinicians. We want to make sure that we've also blinded patients. And we'd like to make sure that we've blinded data collectors. And we'd like to make sure that we blinded data analysts. Okay? So the reason we want to blind clinicians, well, a clinician who is performing a certain intervention but knows what intervention they're performing perhaps, or knows what they're going to perform next and hasn't been blinded to the allocation sequence, and let's say that this clinician doesn't necessarily like the intervention that they've been prescribed to, right? And they believe that the other intervention is a lot better. They may then go ahead, by virtue of knowing the allocation sequence, by virtue of being aware of the randomization sequence, they may then go ahead and potentially perform the other procedure, right? And that's what we call contamination. Or what they might do is prescribe a co-intervention. So something that's not being tested in the study because they believe that the intervention that they've been assigned to was not good, or is not as good as the other intervention, right? So that's why it's very important to blind clinicians, and that would have been performed. Those two things would have fell into detection bias. Well, in performance bias, clinicians may start interpreting and recording results down differently, right? They might start performing tests more frequently. They might start administering more complex tests to measure whatever they're interested in. So that's why we want to blind clinicians. And you might have realized that I said co-interventions and contaminations, and we'll talk about those right after we talk about blinding. The next group of people we want to blind is patients. And the reason we want to blind patients is so that we can reduce the likelihood of the placebo and nocebo effect occurring, right? So we don't actually remove the placebo and nocebo effect by blinding. We actually just balance the two by blinding them. So the placebo effect is essentially an effect where people start to experience positive outcomes because of the knowledge that they're the treatment that they're receiving, and the nocebo effect is when people start to experience negative outcomes for the same reason, that they knew what intervention they were receiving. So when we blind patients, we reduce detection bias in the fact that we're not going to influence their recall or reporting of events. And we reduce performance bias in that if they actually knew what they were randomized into, they might actually go ahead and change their behavior. They might start to seek additional co-interventions and so on and so forth. Data collectors also need to be blinded, right? Data collectors are also susceptible to detection and performance bias. For example, if the data collector knew the randomization sequence, then for performance bias, what they might do is they may go to a group of patients that the interventional control group, they might go to one of the two that they think will perform better and cheer them on a lot more, right? They may treat them differently and collect their data differently than the other group that they think will perform less well. Now, detection bias, on the other hand, for data collectors is they might start to probe issues a lot more carefully, right? They might start to ask more frequent and complex questions in order to collect that data from the group that they think will perform more well. And as a result of just asking more, they might actually see that, right? If you expect to find something, you're often going to find it. So that's why it's important to blind data collectors. And finally, data analysts, they're susceptible to detection bias. If data analysts are not blinded, they might fail to take into consideration every single interpretation of the results that they're looking at. And so we need to make sure that we're blinding data analysts, right? So that's the whole idea of reducing detection and performance bias. Now we're going to get into attrition bias, but the first thing that we want to talk about is co-intervention and contamination, like I said. But we might also want to talk about, before that, what intention to treat is. Because intention to treat analysis is also something very important in the RCT study design. And we want to make sure that studies are using the intention to treat analysis rather than the alternative, which is known as the per protocol, right? The per protocol method. Okay, so what is intention to treat and what is per protocol method? Alrighty, before we actually talk about this, let's quickly just go over what the type 1 error is and type 2 error is, because it's going to tie into this. So type 1 error, type 1 error is essentially when you conclude that there is a difference even though that there isn't a difference, right? It's the probability of erroneously concluding that there is a difference between groups even though that there isn't any. And then type 2 error is the probability of failing to reject that null hypothesis. So it's the idea that you saying that there isn't a difference even though there is a difference. And out of the type 1 error and the type 2 error, type 1 error is the worst one to make. So you always want to make sure you're minimizing type error. It's worse to say that there is a difference even though there isn't than to say that there isn't a difference even though that there is. Okay, so that's the difference between type 1 and type 2 error, and it's going to fall a lot into this discussion here. So the intention to treat analysis is basically ensuring that patients are treated or patients are analyzed based on the group that they were randomized into. So let's say we have two groups of people, right? Let's say we have the treatment group, and let's say we have the control group. And the treatment group is supposed to reduce mortality, for example. Now let's say that before they actually received the treatment, so they were randomized, but before they actually, so let's say right here, they were randomized into treatment and control, but before they actually received the treatment, a patient might have passed away here, a patient might have died here. Well, the per protocol method says that they never received the treatment, so per protocol, given the fact that they didn't receive the treatment, they should be treated as the control group, right? They didn't receive any treatment. The intention to treat protocol says, no, they were randomized into the treatment group, and even though they didn't receive the treatment, they should be treated as though they did receive the treatment. And then you might ask, well, how is that even fair, right? They didn't receive the treatment. Why aren't they being why aren't they being treated as though they were in the control group? And the idea is the intention to treat analysis helps you preserve that randomization and that balance of the prognostic factors, right? So this method is a lot more conservative, and this method, the per protocol method, is a lot less conservative, right? It's going to show us a lot larger in the relative risk reduction, for example, and it undoes that randomization. It's always very important to us that we preserve that randomization sequence, that we preserve the balance of prognostic factors. So that's why intention to treat analysis is so important. Okay, and intention to treat analysis, although it might then increase and contribute to type 2 error, it actually minimizes type 1 error, unlike the per protocol method, which might actually increase our probability of observing a type 1 error. So this is clearly a lot worse than this. Now there is an exception to the intention to treat analysis, and essentially patients who are actually never eligible for participation when they were randomized, they are allowed to be excluded from the data, right? So in order to do this, you actually have to find an independent adjudication committee, and you have to show that the people who weren't eligible, you didn't have the data of the fact that they weren't eligible at the very beginning of the study, and then you can exclude them. So that's the only real exception to the intention to treat analysis. Okay. Now, I talked about co-interventions and contamination before. Basically, what are these? Well, contamination. Let's talk about contamination first. Contamination is essentially when one treatment group or when the control group receives the other group that's being tested, right? So contamination has to do with the things that are being tested. If I have a treatment group and if I have a control group, or let's say I have two treatment groups and I have a control group, right? Or that could be potentially a third treatment group. If somehow my second treatment group received TX1, my first treatment group, and my control group also received the first treatment somehow, then this would be contamination because one of the treatments being tested has been put into one of the other treatment or control groups. Okay, and what this does is that it actually increases our type 2 error. Right, it results in the dilution of the treatment effect. Now, co-interventions, on the other hand, are a little bit different. Okay, so co-interventions. Co-interventions are basically when you start receiving treatments that are receiving something that is not a part of the treatment or control group that is being tested. So let's say again we had TX1, we had TX2 here, and we had a control group here, or potentially a third treatment group. And let's say that these were all some sort of surgical techniques. And this person then somehow received Advil, right? This might be a potential co-intervention. Or maybe they received some other surgical technique that wasn't this or this. Okay? Then this would so that other surgical technique that's not that or that, then this would be a co-intervention, right? And a co-intervention is something we don't want to have. So how do we deal about co-intervention? How do we deal with co-interventions? A lot of the times you really can't do much about them. So you can either rely on randomization to equally distribute co-interventions. But in order to do that, you need a really, really large sample size. So for studies that have a very small sample size, we need to somehow control that co-intervention. So what we could do is you could either forbid them, which usually doesn't work, or you could somehow keep track of the different co-interventions that are occurring and then somehow statistically control for them at the very end when you do your statistical analysis. Okay, so that's the difference between contamination and co-intervention. Whereas contamination is a result of one of the things being tested going into the other group. Co-intervention is something that is not being tested being introduced into one of the treatment or control groups. Alrighty, so now let's talk about attrition bias. We've talked about selection, detection, and performance bias. Let's have a look at attrition bias. All right, so attrition bias has to do with dropping out. Attrition refers to basically dropping out. Now, attrition bias, basically exclusion, is also part of attrition bias, but we're just going to look at attrition bias in the general sense of simply just dropping out, and that has to do with perhaps completeness of follow-up, right? So some of the studies say that the threshold for missing data is 20%. So if you have more than 20% missing data, right? If you have more than 20% missing data, then your ability to support that cause and effect relationship between intervention and treatment might be harmed, right? Now, what if you just had missing data, but it was less than 20%, right? That doesn't mean that it's good, right? Because data is rarely ever missing for just random reasons. It can be missing for random reasons, and we'll take a look at these scenarios later, but rarely is it ever missing for random reasons, right? Most of the time, the people who drop out, or a lot of the times, the people who drop out are different from the people who decide to stay in the study. So when the reason for dropping out is related to the treatment or perhaps the control that they've been receiving, then we know that there's a problem. Then we have something that's harmed our internal validity, right? And sometimes what people do is they increase their sample size to account for the differences. But inflating your sample size, really all it's doing is that it's increasing your precision, right? It's helping your precision, but it's not helping you overcome that threat to your internal validity. It's not changing the fact the people who dropped out of the study were different from those who stayed in the study. So obviously, if you have missing data and missing data was random, then increasing your precision is a good thing, right? But because missing data, no matter what, will threaten your precision, because you have a smaller sample size at the end of the day. But if it was missing because of a reason, because maybe the intervention or the control, then we've started to harm our internal validity, and we need to figure out why the people were missing, right? We want to make sure that the study that's been done has reported the reasons for why people are missing, because that's very important in terms of considerations for internal validity. Alrighty. And we'll take a look at how we can deal with that missing data in a bit. But let's quickly just talk about reporting bias. Essentially, reporting bias is selective reporting really falls under this, and basically it's your differential reporting of results. Maybe you've reported only the significant results and trashed out the non-significant results, right? Or maybe you're reporting something because the funding source is telling you to report them. You need to make sure to look at all of these things, because reporting bias might bias the results at the end of the day. So maybe they were funded, maybe they've only started to report significant results, so on and so forth. And these are things that we want to be on the lookout for reporting bias. So now we can talk about the different ways of dealing with missing data. So jumping a little bit back to attrition bias, right? And we're going to look at 3 different types of missing data. And the first type of missing data we have is missing data that is completely at random. We also have missing data at random, and we have missing data not at random. Okay, so missing data that is completely at random is not very harmful to our results. We could just inflate our sample size, perhaps to increase our precision again. We're not really worried about its effect on our internal validity since it's completely random. For missing data at random, again, we're not really too worried about it in terms of its producing a biased result, because again, it's not missing for any reason related to our intervention. But when we get to missing data that's not at random, that it's because it's related to one of the interventions that we had, right? That's going to be problematic. That's going to affect our internal validity and perhaps produce a biased result, right? So this is what we're very concerned with, missing data that's not at random. We need to understand why people who are missing were missing, to ensure that maybe or so that we can report that perhaps people who were missing were different than the people who weren't missing, or maybe they just had different reasons to be missing. So how do we deal with missing data? And a lot of these missing data are going to be methods are going to be dealing with missing data completely at random or missing data at random, because they're not going to be appropriate for this. For this, we have to figure out why they were missing. All right. So the first thing we could do to deal with missing data is completely just exclude every patient with missing data. Right. Exclude all patients with missing data. And if we include all patients, if we exclude all patients with missing data, that's going to threaten our internal validity, right? It doesn't follow that intention to treat protocol. We want to make sure that regardless of whether they're missing or not at random, that they are included in the study. They're included and they're analyzed based on the treatment arm or control arm that they were randomized to. So if they were missing completely at random or missing at random, that's going to increase our type 2 error. If we did this, and for example, someone was missing not at random, we might actually get a biased result and increase our type 1 error, right? So usually we don't want to exclude people. It's not a really good way of dealing with missing data. The second thing we could do is assume the best case, worst case scenarios, right? This is a very conservative method. Again, might be used in sensitivity analyses. Usually we might have another method in order to deal with missing data, but essentially the worst case and best case scenarios are applicable to studies that have dichotomous outcomes. So perhaps death/survival after the fact. So what we do is we assume the worst case for the experimental treatment arm, and we assume the best case for the control treatment, for the control arm of the study. And we do this in order to prevent type 1 error from going on or from increasing. Again, this seems very, very conservative, and this is not appropriate for longitudinal data that has missing midpoint data. Right? This could be appropriate for missing endpoint data, right? Let's say we have all the data for a person except we don't have this point. We could potentially use the best case, worst case scenario for this. But if we had missing midpoint data where we were potentially, let's say, missing this point, right? A person was missing for this, we couldn't use this. We need to use another method to come up with missing midpoint data. So the person showed up for this, the person showed up for this, but they didn't show up for this. We need another method to do this. One of the ways that we could do this is actually growth curve analysis, which will not be discussed in this video, but growth curve analysis is one of the ways that we could deal with missing midpoint data. Now, I said this was for dichotomous data, dichotomous outcomes. We could use the last outcome carried forward analysis, which is used for continuous data, right? Essentially, what we do is we carry the last visit all the way to the next point, right? And what we do is we start to lose the trajectory of change, right? If the person's increasing, we start to lose that, right? Because then they'll be put here. We lose that trajectory of change, whether they were increasing or decreasing. So again, it's a pretty conservative method. It's appropriate for continuous data, but again, not appropriate for longitudinal data that has missing midpoints. We can only use this for missing endpoint data, okay? Now, what do we do for missing midpoint data? Well, not yet, but we could also perform regression, right? And what we do is we take the mean score, we regress it, we regress everything to the mean, and then we come up with an average score and we put it onto our next point, right? So it's essentially a way of predicting the next score. And regression methods are appropriate for continuous data. They're also appropriate for dichotomous data. But the idea is that regression methods, because it's taking and aggregating all this data together and averaging it, what it's doing, or not because of its aggregate, it's not aggregating data, right? It's ignoring the aggregation, and what it's doing is it's assigning a fitted average score. What it's doing is it's decreasing that variability in the data. So it's going to increase the probability of you making a type 1 error, right? So, how do we deal with missing midpoint data? And aside from the growth curve analysis, which I'm not really talking about, and what do we do if we don't want to use regression, right? because these were too conservative. This one was less conservative, but it's increasing our type 1 error. Well, what do, right? There is a method, and this is going to be our fifth method of dealing with missing data. And that method is called the multiple imputations method. And we're going to call this the MI, right? Multiple imputation method. I'll just say MIM. And what multiple imputation method does is that we use basically several different methods, right? Let's say that we have let's say we have I number of data sets, right? And what we do is we perform an M number of analyses. We perform an M number of analyses on these data sets, and then what happens is that we consolidate, and the M number of analyses comes up with an N number of results, right? And then all of these results are then consolidated into one single result. And that's what multiple imputation methods are doing, right? We're not also to perform these analyses, we're not just using one single method. We're going to be using several different types of methods. Like, for example, last outcome carried forward could also be considered a imputation method. Perhaps we could use that imputation method here. And the reason why multiple imputation might be better than regression is because it starts to aggregate that data together. And because it's aggregating all that data together, it's not reducing the variability by as great an amount. So what it's doing is there's a less increase in that type 1 error. Again, for data that's missing not at random, this isn't appropriate, right? We need the reason for people who are missing not at random. But this is appropriate for missing midpoint data, right? So we can erase this now. We've talked about basically 4 different ways to deal with missing data, and one of the ways that we could deal with missing midpoint data was using that multiple imputations method. Okay, so some important considerations when we look at missing data. Obviously, we talked about the threshold. 20% has been reported as one of the thresholds. So if you have more than 20% missing data, then you might have a problem making some sort of valid conclusion, right? You want to make sure that missing data is balanced between your treatment and your control group. Otherwise, if one of your groups has more missing data than your other, then there might actually be a real reason as to why someone's missing. They might be MNAR. Did the study use any form of imputation or any form of imputation, potentially any form of dealing with missing data, and was it appropriate? And you want to make sure that they also perform some sort of sensitivity analysis, right? And sensitivity analysis is the method by which you check the robustness of your results. Let's say you had a p-value, and you got your p-value to be significant as 0.02, right? And let's say that you had a lot of different dropouts, and you're concerned with whether or not that p-value is actually robust. If you continue to count those dropouts as people who failed the treatment, right, which is how it should be done, then and you get a p-value of 0.03, then you could say, okay, my results were probably robust. But if you got a p-value of, let's say, 0.1, then your results were probably not robust, and the data might have actually not been missing at random. Okay, so those are some things that you want to make sure when data is missing. You want to ensure that data is not missing for not random reasons, and if it is, then did they figure out why the data was missing? Alrighty, so now we can talk about random sampling error. Whoops, let me just erase that. And let's talk about random sampling error. So this is one of your potential random errors. So all of those were potentially affecting your systematic error, right? Potentially systematic errors. Now, random sampling error is occurring because of a whole bunch of different things you've done. Maybe you have very small population, right? And as a result of having a small population, the observed results that you saw was simply just by chance, right? And through random sampling error is just asking, through random chance alone, it's possible that we picked as people that aren't representative of the population. So the results aren't going to be very valid. So we can't really get rid of random sampling error. We need a large population size, very large population. And the greater the population size, or sample size, we have, the lower our random sampling error. The only way we can be completely rid of random sampling error is if our sample size was our population size. Okay, so we've talked about type 1 and type 2 errors now, right? But what happens when, or how can I define my probability of a type 1 error, right? So let's say I'm making several different comparisons. So I have a treatment group and a control group. Treatment group, and I have a control group. And I'm making a lot of different comparisons. Maybe I'm looking for, in treatment and control, maybe I'm looking for pain. Maybe I'm looking for happiness. Maybe I'm looking for sadness. And maybe I'm just looking for a whole bunch of different things that are not related. So all of these things are independent. Well, the idea here is that with every statistical independent test, with every independent test that I'm making, my probability of finding something that is statistically significant just through chance alone increases significantly, right? So if I'm going to measure something, if I'm going to perform a study, I want to make sure that I'm not performing too many independent comparisons. Now this doesn't apply to, for example, if I was measuring pain by using a couple of different outcomes, right? If I had a pain rating scale and if I had another pain rating scale, these don't count as independent comparisons because they're all related to they're not independent, they're related to pain, right? But if I had multiple independent comparisons, if I had multiple independent things that I was looking for, I'm increasing my probability of type 1 error. And I'm going to put a question example in the description to calculate the number of independent comparisons that a study might have possibly had. But here's the equation of the probability of making a type 1 error. And essentially it goes like this. So you take the 100, which represents just the probability out of 100%, and you're going to do 1 minus 0.95 times n. Okay, where n represents the number of independent comparison. This now becomes your probability of making that type 1 error. And remember, no matter what, you want to reduce your likelihood of making that type 1 error. You don't want a type 1 error to actually happen. So in that scenario, and understanding that, you also want to have as little independent comparisons as possible. Okay, and subgroup analyses actually also contribute to independent comparisons. So when you start to divide groups after your initial comparison, when you start to divide groups into, let's say, two different groups, so we have male and female groups, and you want to compare between these two subgroups, right? Between male and female. Let's say we were looking at knee injury, right? Knee injury in, let's say, in braced versus non-braced skiers. And let's say then I want to look at, okay, knee injury in braced males and knee injury in non-braced males, and I want to compare that to knee injury in braced females and knee injury in non-braced females. Well, that's also going to contribute to my independent comparisons. Subgroup analyses are also going to contribute to that. Okay, and all of this is going to be in an example in the description below. So you can take a look at that. That's the whole idea of random sampling error and potentially making multiple independent comparisons to increase your probability of a type 1 error, which you don't want. So what do we do if a study has actually done some sort of, if a study has actually created independent comparisons, right? Their probability of type 1 error has increased. So the idea is that 0.05 p-value, the idea, your ability to get a p-value less than 0.05 might actually be easier now, right? So that 0.05 is no longer a valid threshold. So what we do, and there's this thing called correction method. It's called the Bonferroni correction. I should put two R's there. Bonferroni correction. And what Bonferroni correction does is it takes your p-value, right? So let's say we take 0.05, which is our traditional threshold, and we're going to divide it by the number of independent comparisons. And let's say we had 10 independent comparisons, for example. Then what that becomes is our new p-value is now 0.005, right? Now this, in order for us to detect any statistical significance, our p-value now has to be less than 0.005 in order to declare statistical significance. This is a very, very conservative method. There are other methods available that are less conservative. Okay, so that has to do with multiple independent comparisons also. Jumping to the next topic in RCTs, we are also concerned with interim analyses, right? Sometimes you might see a study was stopped in the middle because of a couple of different reasons. So maybe, well, there's three reasons. The first reason is because of efficacy. The second reason would have been because of harm. And a third reason was because of futility. So let's talk about these two first. If you're able to show that you giving out your treatment is causing significant harm to patients, and you want to and you're able to show that as compared to your control group, then you're able to stop the study midway and show that that treatment and do an interim analysis and show that that treatment was harmful. Again, futility. If you're able to show that it's unreasonable to ever expect a difference, right? That futility, it's futile to expect a difference, then it might be reasonable to just say, okay, I'm going to stop the study, right? Efficacy is the problematic one. Efficacy is the one that's the hardest to show, right? If you're able to show that your treatment is so much better than not giving you the treatment than the control, right? That it becomes very unethical to actually withhold that treatment from the control group. Then you want to propose stopping that study, right? But how can you actually stop the study early for efficacy, right? The idea is that in order for you to have stopped your study for efficacy, your p-values must be extremely stringent. So your p-values must be very strict. That you must actually have a very large number of events in order to stop for efficacy. And really, one study has shown that it really needs to be, it should be very studied to stop the study early, right? It should be difficult to see the amount of events to stop the study for efficacy until we've actually reached the full sample size. So if you see a study that is stopped for efficacy, you want to make sure that they actually did plan ahead, that they did have stringent p-values, that they did consider, and that they did have a lot of events happening, right? So these are the three different ways through which you might actually perform interim analyses and stop the study early, this one being the hardest one to actually perform. Okay, so that brings us into sample size considerations. So this is all about precision now, right? Alrighty. So if you remember, we talked about MCID values, creating those margin of superiority, that margin of non-inferiority, whatever it might have been, right? Well, there are sample size calculations for different hypotheses that you might want to make. And the idea is that when you're making sample size calculations, you want to make sure that you've done your sample size calculation a priori, and meaning that you've done this has all happened before you actually had any sort of observation of data, before you actually analyzed your data. But if you did it post hoc, meaning that you've made your analysis, you've considered or your sample size after the fact, after you've done your analysis of the data, well, it's always easy to say that this is what I saw after you've seen it, right? So post hoc is not the best way to do it. That's also called a power analysis method. You want to make sure that sample size was done a priori, right? Sample size estimation is the best way to go. And a priori, we're trying to determine n, where n is the sample size. Right? We obviously know what the power is because it was done a priori. So we're going to set a power. We're going to set a type 1 error rate. So we've also set the type 2 error rate by knowing the power. And we're going to say this is and we're also going to set an effect size. So this is what we call a delta value. That doesn't look like a good delta. But we're going to set a delta value and say that I want to see this big of an effect. And we're going to estimate that sample size. For things that are done post hoc, and you'll see why this is a problem in a minute. But things that are done post hoc, well, you know your type 1 error rate. You know your sample size now because you've done the study, and now you know your effect size. So you've done the study, you've analyzed it, you've seen the difference, right? The only thing you're missing is power. So you're going to go back now and say, this is how much power I had. It's always better to say, It's always better to make an a priori hypothesis, and it's very important that you do that in order to reduce the risk of falsifying your results. So a priori sample size calculations are very, very important. Now, remember, p-values aren't as important to us now. We're in a randomized control trial. We're in a clinical setting. We're not very worried about p-values. We're worried about margins, and we're worried about effect sizes. And we'll talk about effect sizes in a bit. So, let's talk about, I guess we could jump into equality studies first, because that's the first thing we looked at in the first lecture. So, for equality studies, how can I calculate my sample size? Well, I need to make sure that I need to first realize whether or not my outcome is continuous or if it's dichotomous. If my outcome is continuous, then my sample size calculation is going to look like this. 2 times z alpha over 2 plus z beta squared, and then we're going to have a standard deviation value here, and we're going, oops, I'll just leave it, and then we're going to have the effect size. Okay, so that's my delta, and we'll talk about these components in a bit. So this is if it was continuous. If instead it was dichotomous, then my equation is going to look like this. It's going to be a little bit longer, so just bear with me. Z alpha over 2 plus Z beta squared times P1 times 1 minus P1 plus P2 times 1 minus P2. Oops. And then you're going to divide that by the effect size squared. Sorry, that looks a lot like standard deviation. Just know that this is effect size. This is my delta value. So this is for dichotomous outcomes. Alright, so the general equation is going to stay pretty similar across the different types of studies, but for equality, these are the two different equations that I'm interested in. Alright, Z alpha over 2 is simply just your Z value for a two-sided confidence interval. Z beta is your Z value associated with the power that you've chosen in the type 2 error rate. Standard deviation is your standard deviation of the population, potentially also your sample, because the standard deviation shouldn't really have changed, and your delta is your effect size. Now, for any sort of continuous measure, and this is continuous measure, whoops, and this is going to apply to not only equality but also superiority, non-inferiority, and equivalence studies. Your standard deviation could potentially be a Cohen's d value. So, I don't want to erase the sample size equation. So Cohen's d is given as, let me just move this down. Cohen's d is given as, we'll call this d, mean change, so we'll go mu2 minus mu1 divided by the standard deviation. So we know the standard deviation, but we're trying to estimate the effect size, right? This is our effect size. It's the difference between it's the difference that we're expecting to see. Well, what we can do is what we can do for our estimated effect size is we can take a Cohen's d value and multiply it by the standard deviation. Right? And you might be wondering, well, what's Cohen's d? Well, if I'm expecting a small change, then I can multiply my standard deviation by 0.2. If I'm expecting a moderate change, then I can multiply it by 0.5. And if I'm expecting my standard deviation, and if I'm expecting a large change, right, then I can set my Cohen's d to something that is greater than or equal to 0.8, and I can multiply by my standard deviation and say, okay, this value of Cohen's d times standard deviation gives me a large expected effect size. And these are just values that are set by Cohen, and that will become my effect size at the bottom here. Okay, so this could potentially replace this here, right? It really is the same thing, because this is equal to this, and if this is equal to this, then this is also equal to this. Alrighty? And that's for any sort of continuous measure. So this will also apply to the other types of studies, research hypotheses that we're going to look at. So that's Cohen's d. And now you might be wondering, well, for my bottom in my dichotomous outcomes, what is this delta going to represent? Now that's very messed up delta. Well, you need to understand first what the P1 is and what the P2 is. And P1 is the expected event rate, right? Is the expected event rate in the treatment group. Okay? And P2 is the expected event rate in the control group. Alrighty? And by event rate, I mean like if you're looking for something to happen, then what is the proportion of people that thing has happened? What is the proportion of people that thing has happened to? Right? Okay. So that's P1 and P2, and your delta value is going to be given by P1 minus P2. All right. That's this is for any sort of dichotomous measure. Again, this applies to not only equality studies, but also it applies to superiority, non-inferiority, and equivalence studies. Alrighty, so that's equality studies. Just erase this now. And we're going to get into our next sample size consideration. And we're going to look at superiority studies. Sample size consideration for superiority studies. Okay. Superiority. So, for continuous superiority studies, and remember, in superiority studies, we actually had a margin. So you might expect a value of the margin to come up. For superiority studies, for continuous measures, we still have this same numerator, z alpha over 2 plus z beta squared times that standard deviation squared, divide that by, okay, I should really figure out a new way to write that delta. Let's write it like this. Delta minus m squared. Okay. Again, delta is the same thing, but this time your margin. Right? This time you have your margin here. So this is your MCID value. It could be your MCID value rather. And essentially, let's draw that diagram out again. And let's take a look at what's happening here in this sample size equation. And let's say this is my important difference, and this is my expected effect size, and let's say this is my second expected effect size. Okay, so this here, my MCID, might be my margin. This is my expected effect size, so let's look at this one first. Okay? So obviously, I'm going to take this value, and I'm going to subtract it by this value. And I'm going to get some sort of difference at the bottom, right? Now the relationship here, because this is sample size, oh, and I forgot to say that for all of these sample size, the sample size is n per group. So this is the amount of people that you need per group. Okay? You might then say, okay, well, it's not enough that I know my delta, and it's not enough that I know only my margin, right? I need to know both of them in order to consider what's going to happen to my sample size. So the relationship here is that the closer my margin is, or the closer my margin and delta are, right? Let's say I have, let's say this is 10, let's say this is 5, and let's say this is 2, right? 10 or 5. The closer my margin or delta are, and even the further apart they are, the bigger the numbers are. Actually, let's actually do the calculation. So I have 10 minus 2, which is going to be 8, and I have 5 minus 2, which is going to be 3, right? So which one is going to make my sample size a lot bigger? Well, obviously, if I have a smaller number in my denominator, then I'm going to be increasing my sample size, right? I'm going to be increasing the number on this side. So the closer my margin is to my expected effect size, the bigger the sample size I'm going to have. The further my expected effect size is away from my margin, the smaller my sample size is. So that sample size is driven by the relationship between my margin and my expected effect size. In order for me to get more precise results, something that's closer to my margin, right, I need to have a larger sample size. I need to be a lot more precise. Something that, if I'm looking for something that's very large, expected effect size, I might be prone to random sampling error. So I probably won't need as many people in order to detect something like that. The more precise I am, the more closer I am to that boundary, I'm going to need more people. That's just the way I see it. So that is the idea of a continuous sample size equation. For a dichotomous sample size equation, we're going to write it like this. We're going to take, it's pretty similar again, take that z alpha over 2 plus z beta squared times p1, 1 minus p1 plus p2 times 1 minus p2. And then we're going to go like that, and we're going to put the denominator again like this, delta minus m squared. Again, p1 and p2 represent the same thing. Okay, now this is the exact same calculation for non-inferiority studies. Okay, exact same numbers, exact same calculations. Equivalent studies, it changes a little bit. Okay, so let's write out the equation for the equivalent studies. Again, this was n per group, and yeah, both of these work for superiority and non-inferiority studies. So I want to essentially erase the denominator here. The denominator is the thing that's going to be changing. Alrighty. So for equivalent sample size calculations, studies that are looking at equivalence, I'm going to take my margin and I'm going to subtract it from my absolute value of delta. Okay, same thing down here, margin minus, whoops. Okay, that's delta. Alright, so M again is that superiority or, M is that just superiority or non-inferiority margin, because on either end it should be pretty much on the same distance away, right? And my expected effect size is again somewhere on one of these ends. But the relationship changes a little bit, right? Let's consider a margin again that we had at 2, right? And let's say we have our expected effect size at 10, and let's say we have an expected effect size at 5, right? So where is this? Alrighty, so 2 minus 10 is going to give me minus 8. 2 minus 5 is going to give me minus 3, right? Similar thing is happening, but this time I'm taking a look at its relationship between I'm taking a look at this relationship, right? Because my margin is first now, the relationship is still being driven by n per group. But now my margin is on this side of the equation instead of being on this side of the equation, right? So 2 minus 10 is giving me minus 8, squared is still positive, 3 squared is still positive. But I want to make sure, let me erase this. Another way I should actually explain it is that although the relationship is still there between these two values, what I really want to see, and I should have specified, it shouldn't have actually been like that, my bad, because the effect size we want to see is actually supposed to be in here somewhere. So these values are actually not feasible. Let's say my margin was actually 10, and let's say that these values were, let's say, 5 and 2 instead. And yeah, so this makes a lot more sense. So ignore everything I said before, that was my bad. So 10 minus 5 is 5, and 10 minus 2 is 8 again. So again, the closer my margin was to my expected effect size, right? So 5 and 2. The smaller number, the number I'm going to have in the denominator, the greater my effect size, the greater my sample size, right? If I'm expecting something further away, then obviously what's going to happen is that my, if I'm expecting like an effect size that's further away, closer to this line, closer to the no difference line, then obviously I'm going to need, like in this case, obviously I'm going to need less people as compared to something that is closer to the margin. But another consideration is how wide apart are our margins. And the idea is that the closer your margins are together, this is what the additional consideration is that you need to make. The closer your margins are together, the more narrow your confidence intervals are going to have to be, right? So the sample size calculation is going to be affected by how close or how far apart your margins are also. The closer your margins are together, the more narrow your confidence intervals are going to have to be, so the greater the precision you're going to have, meaning the more people you're going to have in your study, as compared to margins that are not as close together. That's just the difference between the two here. So that basically takes care of internal validity, takes care of precision, and we're really left with external validity. And for a discussion on external validity, I'm not going to go through it in the video, but I'm going to basically include a whole description of it in the discussion section, or in the not in the comment section, in the description section below the YouTube video. So just take a look at that so that you're not left without a discussion on external validity. Okay, I hope that helps.